Pain is more than a symptom. It's a silent epidemic. And for some, it becomes a battle for life itself. This is tragically true for those with trigeminal neuralgia, a condition creating such excruciating electric shock-like facial pain that it has been called suicide disease. The unbearable nature of this pain drives many to despair. It's a reality actor Salman Khan brought to light, describing his own journey in the condition as agonizing.
There was a full performance of it. So really? Yeah, 5 minutes later my makeup man touched me. I said, "Ye kuch gadbad hai yaar."
But there was a painting on the
Knees like a
You'd never felt it before.
Never felt it. And every time I watched my face, sat in the window, it just and then it happened, kept on happening. I thought it was a sinus problem. You know, I did treat it. It didn't go. From there, it moved here. So this went on for about 4.5, 5 years. 2 years, it came down here. These 2 years were the most painful. Every 35 to 40 seconds, it used to give me a current, but it was foaming at least about 10 to 15 feet. I used to go like that. So then first they thought it was a dental thing. After the dental thing, they thought it was mouth cancer. I said, baap re baap, ye kya hai naya. So then they ruled that out. And then one of the doctors asked me, so when does it like ease out? You know, Arnab, it used to take me 45 minutes, an hour and something to eat one omelette in the morning. Ye lunch break, kya hua hai? And then dinner, I should pick out 1 or 2. And then I could eat. So that's how they found it. It is a nerve problem.
But how do you fight an enemy you can't see? That's where the specialty of pain management becomes critical. In this episode, we explore this world with Dr. Sadasivan Iyer, a leading consultant pain physician at Manipal Hospital's Old Airport Road. Dr. Iyer is an expert in alleviating conditions that are often left behind after other treatments are complete. He manages a wide spectrum of debilitating pains, from chronic back pain and severe headaches to nerve-related neuropathic pain, cancer pain, fibromyalgia, etc. He uses advanced interventions like radiofrequency ablation and minimally invasive procedures to give patients their lives back. This is why the relationship between a neurosurgeon and a pain physician is so vital. A neurosurgeon like Dr. Sharan Srinivasan performs a life-saving operation, but the journey doesn't always end there. For the complex lingering pain that can follow, be it from a nerve issue, the surgery itself, or an underlying condition, Dr. Iyer comes to the rescue. He has been an integral part of our rehab team and brings progress in our patients' rehab journey and comfort to them in times of need. Their collaboration is built on a shared understanding that healing requires more than just fixing the initial problem. It all comes down to Dr. Iyer's core philosophy, a motto that guides his entire practice. Pain is inevitable, but suffering is optional. This is Rebooting the Brain, and today we are here to help you understand how to choose relief over suffering.
ജ്ഞാനാനന്ദമയം ദേവം നിർമ്മലസ്ഫടികാകൃതിം ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവം ഉപാസ്മഹേ ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവ ഉപാസ്മഹേ ഹയഗ്രീവ ഉപാസ്മഹേ.
Rebooting the Brain, powered by PRS Neurosciences. Namaste, everybody. Om Asatoma Sadgamaya Tamasoma Jyotirgamaya Mrityorma Amritam Gamaya Om Shanti Shanti Shanti. This shloka has been a big inspiration for me and a driver for what I do every single day. And as the shloka says, from darkness to light, from ignorance to awareness and enlightenment, and from death to immortality. This can be used in any aspect of your life at any time to look at how you can be a better human being compared to yesterday, how much your knowledge can improve, so on and so forth. So, guys, I recommend you people to try to use it and see whether you can benefit it as much as I have benefited. Hi, everybody. My name is Dr. Sharan Srinivasan, and I'm a functional and stereotactic neurosurgeon from Bengaluru, India. Welcome to our podcast, Rebooting the Brain. So, before I go ahead with the guest of the day, I want all of you to subscribe to our channel if you haven't already done it, and then share this video because you never know who will be helped. Like it, and definitely press the bell icon. And don't forget, once you get into the channel, to look at Rebooting the Brain documentary. There's also Rebooting the Brain book that we have written. It's at the back, as you can see. It's available on Amazon, both the Kindle version and the hardbound, whichever you want. You must buy it and read it because you never know which part of neuroscience you or your family may need. So as I go ahead with this, let me introduce you to our guest of the day, Dr. Sadasivan Iyer, an intervention pain physician from Manipal Hospital, Bangalore. Sadashiv, welcome to our show, and it's an honor and pleasure to have you here, and we've been great friends, so I'm quite sure we're going to have a good chat. So you want to say something to our visitors, to our viewers? Please go ahead.
Thank you, Sharan sir, and the team at PRS Neurosciences for having me here. My association with Dr. Sharan started way back in 2015 when I met Dr. Sharan at a pain conference, and it was very surprising. So I thought he was one of the delegates who wanted to come and learn a little bit of needling, but Dr. Sharan came in as a faculty, and I have worked with a few neurosurgeons, but it was the first neurosurgeon I saw who was talking about pain, who was talking about blocks, who was talking about needling, who was talking about avoiding unnecessary surgeries. So I went up to him and asked, "Sir, are you from Bangalore? Are you from some other part of the world?" He said, "No, I'm from Bangalore. I practice at Jain." And then I decided that day that at some point of time in my career, I would want to work with him, and thankfully that opportunity came 3 years later. So from there on, things have just progressed forward. We have not looked back. Thank you once again for having me.
My pleasure. Thank you so much for your
Thank you,
kind
sir.
words. So you just saw the Salman Khan video. We know Salman Khan as a Dabang star. We know him as the six packs and all of those things. Everybody knows him for that macho thing. And he's talking in the video of his personal experience with something called the suicide disease. Is there really something called that? I mean, what is that all about? He's holding his hand like this. He's saying how it went here, here, here. What really is going on with the guy? Poor guy. He was struggling for such a long time. Can you tell our audience what this is all about? What was he talking? We'll go deeper later, but just as an introduction.
So Mr. Salman Khan had a condition called trigeminal neuralgia, which in colloquial terms is called suicide disease.
Okay.
What happens is we all have 12 nerves in a face, and the fifth nerve is the most important nerve when it comes to transmitting sensations and moving your mouth and your jaw. The fifth nerve can get irritated or compressed at any point of time from its course in the brain to the face, and a compression of that nerve causes irritation of that nerve, and any nerve related pain, we call it neuralgia. So this is called trigeminal neuralgia. It's one of the most painful conditions ever known to mankind.
I agree.
And pain can be so intense that it can drive a patient or a person to commit suicide. So therefore, it's called suicidal disease.
Amazing. So pain, you use the word pain. and I introduce you as a pain physician. Are you called pain physician because you create pain for other people, or what's going on? Because I know I heard one of your interviews where I was there when that news anchor asked you, "Sir, you actually doctor, sir, you." Which means, are you really a doctor? Which means, imagine if a news anchor who's supposed to be worldly wise got a lot of information with the 4Gs and 5Gs and Googles and Chat GPTs around from the Silicon Valley of India, which is the IT capital of India. If she hasn't heard of the word pain physician, so my belief is you guys are doing a bad job of promoting yourself because everybody has pain. So, but how come they don't know about you? So, we need to know now, why are you called a pain physician? What is pain? Let us start with the fundamental things. What is pain? Because, like my board says here, pain is a pain is a pain. So, please tell our global audience, what is pain?
So pain can be either something you can either have it as a sensation, or it could be a person who's really irritating you down, right?
Got it.
But pain in very colloquial terms is anything that the patient says hurts is pain. Right?
Got it.
Um, there is a society called the International Association for Study of Pain, which has defined pain very elaborately. I'm not going there. But what they thought was an initial physical component has now, over the years, been found out to have a psychological component, an emotional component, and an interplay between the physical, psychological, and the emotional component is what we see outside.
So, you're saying that pain is coming, my back pain is coming from here?
Could be.
What? So
Yeah,
we'll have to dig down there and see whether my back is upside down or
upside down.
what's going on.
Because most of the time when patients have pain in the face, the first doctor they visit is a dentist. I've had a patient who came in with a V2 neuralgia,
Okay.
a neuralgia on the second portion of the face. And she came in with one set of teeth gone on the top row, and
I have seen, yeah.
you've seen that.
Yeah.
Right? And then they go pulling one teeth after another teeth after another teeth. They visit multiple dentists. Many of them think that there is a problem. Inevitably, at some point of time, we all will develop some caries in our teeth, but that is not the source of trouble. On a very rare occasion, the converse happens, wherein you could have a dental extraction, and because of the extraction, the nerve underlying can get exposed or irritated, and that can precipitate a trigeminal neuralgia.
You are by qualification a doctor, so can you tell them what kind of a doctor becomes a pain physician so that they can understand? Let us go from the basics so that there's no controversy about what a pain doctor is.
The beauty about being in India is all healthcare related personnel can be called pain physicians.
What do you mean?
You have a headache, you don't visit the doctor. You go to the nearest pharmacist. That guy gives you 2 tablets of paracetamol, says, take it 2 times a day, your headache will go. And by the second dose, your headache is gone, right? So you have pain physicians who are starting from being pharmacists to your MBBS doctors, as we've all trained in MBBS. At the end of the MBBS training, we can all treat pain, right? Just like we are legally allowed to do cesarean sections, conduct deliveries, but we can also manage pain. 2 specialists who have done their training in either anesthesia, neurology, neurosurgery, orthopedics, rehab physicians, and done a subspecialty training in pain medicine. So the spectrum of people who can be called pain specialists are quite diverse. But most of them are either anesthetists in background training, and then go on to do some subspecialty training.
Anesthesiologist.
Yes.
That means I always say they put people to sleep.
Yes. So we can also take away the patient's pain.
Correct.
We're trained to do that.
Got it. So yes and no to that. So I know most anesthetists treat acute pain, which is during the surgery or during an injury and things like that, which is, I think, relatively easier to treat. So we know, like you said, most of these tablets are given, something is done. So, but I know that why you're sitting in front of me today is to talk about a phrase which very few people know and fewer understand. It is called chronic pain, not acute pain. So can you now tell our viewers what is chronic pain and how is it different from acute pain?
Chronic pain is anything that lasts, any pain that lasts in your body for more than 3 months is technically called chronic pain. That is lasting
Anywhere in the body.
anywhere in the body, lasting more
Got
than 3 months, right?
got it.
That's 12 weeks.
Okay.
That's a very technical cutoff, right?
That's
Acute
what
pain,
people always ask. What about 11 weeks? What about 13 weeks? So we'll leave it at that.
we'll leave it at that, right? So, as a technical description is 12 weeks. So, anything more than that, your pain tends to become chronic.
Got it.
The idea is the pathology then starts moving from the site of injury to having chemical changes in your brain and spinal cord.
Got it. That's where it starts.
That's where it starts becoming more complex.
And more stubborn.
Absolutely. And more difficult to treat, more resistant to treat, causing all the emotional and psychological manifestations that we see in patients with chronic pain.
Got it. So that means unlike the acute pain, the results are not magical more often than not, though you have some interventions to make that happen.
Acute pain is probably the source of chronic pain. Nobody is born with chronic pain. You would have had that pain being acute at some point of time.
Point taken.
Right? So that's the mother. And the offspring is the chronicity that it causes.
I think that was a profound statement. I had also not realized that, having seen pain every day.
So that's the advantage of being an anesthesiologist as well, because you get to see spectrum of the acute pain. We strive hard to leave it there, to break it there. It doesn't become chronic. Because once it becomes chronic, then we're fighting a different battle altogether.
I got that. Which is why the battle, you say, is your motto statement, which is pain is inevitable. I think all of us human beings at some point of time in our life will have some pain.
Absolutely.
And we will talk about all those pains. But like you said, suffering is optional.
Absolutely.
Now, why do you make that statement, suffering is optional?
So like I said, chronic pain comes with a baggage of psychosocial, emotional disturbances. So when you suffer, what is it that you're going through? Suffering is a very broad term to describe a multitude of feelings that you're going through.
Got it.
Right? You could be suffering because the pain is disabling, so that you don't have a job. You are not able to do your day-to-day work. Right? You are left incapacitated to do things that you were doing some time ago.
God, yes. A lot of people say that.
A lot of people say that, right? I'm sure you know. You're a functional neurosurgeon.
Yes.
So that is what we want to avoid.
Got it.
There is no way on earth any of us can take away somebody's pain. In fact, pain is a blessing, because the pain is acute pain, for example, is supposed to be protective.
Correct.
Right? If you have a candle and you put your finger in, your body tells you, please take that finger away.
Correct.
Otherwise, you'll end up burning your finger.
Very well said.
So pain is a protective mechanism telling you, please stay away.
Very well said. So that's why when you have chest pain, people go to the hospital thinking it's heart attack.
Absolutely.
But because stroke doesn't cause pain, they don't come to the hospital. So the brain is doing disservice to us by not giving us the pain that we want to have.
No, but more often than not, during the stroke, there are telltale signs which the patients don't really know.
Yes, our other podcasts have covered those topics very effectively. That we recommend you guys to go and look at that if you haven't already. So coming back to our dear, friend and superstar Salman Khan and the disease he has suffering from called trigeminal neuralgia.
ये एक बीमारी है जिसको बोलते हैं ट्राइजेमिनल न्यूरालजिया। अब वो ट्राइजेमिनल न्यूरालजिया के अंदर ये होता है कि इतना दर्द होता है कि इट इज़ कॉल्ड सुसाइड डिजीज। मैक्सिमम अमाउंट ऑफ सुसाइड्स आर कमिटेड बिकॉज ऑफ ट्राइजेमिनल न्यूरालजिया।
Now, you see very clearly in that interview with Arnab Goswami, he's saying, first it came here, then it came here, then it came here. And once it came here, he couldn't swallow, he had problem eating, it would take 1 hour to eat, and so on and so forth. I mean, is it spreading or what's going on here? Or what is it? And his actions are quite dramatic, which shows that he had a lot of pain,
True.
And knowing heroes who are supposed to tolerate a lot of pain, he looked very distressed just describing it. Yeah.
Which is true, sir, because a lot of patients, when they come to our OPD, they are very distressed. It can be quite distressing. To say that the pain spreads is not true. It's just the different portions of the nerve that is damaged because of the long-term compression. And the fifth nerve breaks into 3 parts on the face. So the one part goes to the eye and above the eye. The one part covers the cheek, and the third one covers the jaw. So you could have a nerve damage or a nerve irritation in any of those three parts.
Got it.
You could have it in one or more than one. You can have it in all three parts of the nerve, and extremely distressing and very, very painful.
Got it.
We've had patients who've come screaming to the OPD.
You know,
You've
we also
seen it.
operate patients
Absolutely.
with a subset of patients who need brain surgery, for that.
For the same.
But no, I agree with you. So, like what he's saying, it has three branches. You have the V1 here, the V2 here, the V3 here. Depending which branch gets affected, in layman's terms, we call it a V1 neuralgia or a V2 neuralgia or a V3 neuralgia, all three of them, depending on what it is. So, and he said until it became V3, he didn't have problem in eating.
Correct.
And this is a very sharp pain, as our patients complain, very sharp, like a knife going through their face. And then, but it lasts very short period of time.
True.
It doesn't really last longer, and but then the pain sometimes hangs around. But then comes to the very interesting question. Next question is, he is saying Salman Khan, multi-millionaire, maybe a billionaire, I don't know. He's sitting in Mumbai, which is not a village. It's the financial capital, the who's who. Some of the best, the biggest doctors, hospitals are there. Yet he says in that video, he took 5 years to reach the right doctor, to get the right diagnosis. I mean, doesn't it sound very strange, sad, funny, whatever word you want to use? That they thought it was a dental problem first, then they thought it was a cancer next, and then eventually landed. I mean, 5 years? I mean, is that even possible? Why is that going on?
Because most of the time when patients have pain in the face, the first doctor they visit is a dentist. I've had a patient who came in with a V2 neuralgia,
Okay.
a neuralgia on the second portion of the face. And she came in with one set of teeth gone on the top row, and
I have seen, yeah.
you've seen that.
Yeah.
Right? And then and then they go pulling one teeth after another teeth after another teeth. They visit multiple dentists. Many of them think that there is a problem. Inevitably, at some point of time, we all will develop some caries in our teeth, but that is not the source of trouble. On a very rare occasion, the converse happens, wherein you could have a dental extraction, and because of the extraction, the nerve underlying can get exposed or irritated, and that can precipitate a trigeminal neuralgia.
Got it. Yeah.
So the converse is true in few occasions, but most often from what we see is that the dentist is the first go-to doctor when it comes to any form of facial pain. Unfortunately, diagnosis takes a little time because we look at innocuous things first to be trying to give us an answer.
Yeah, which I agree. I mean, it's not. But honestly, Sadashiv, considering that I also see these patients every time, I somehow beg to differ on this because eventually we are clinicians. We are not a robo. If you spend some time eliciting the history and the type of pain and the way it comes and goes and the precipitating factors and everything else, I think within some time you can have a level of suspicion. You may not be able to say, yes, this is the diagnosis, but definitely trigeminal neuralgia can come as one of the differential diagnoses that you're having. And you look at the simpler things first before you label them that, because it has a different connotation at the end of the day. And like you said, I have had most of the patients who come to me have had at least 3 or 4 teeth pulled before they come. And this is my honest thing to all the dentists who are listening or anything else. Please understand that you have to train all your students that if they have a pain in a pattern like this, trigeminal neuralgia has to be entertained. And I would recommend you to send to a specialist like us before you decide to pluck any of the teeth, unless you have a real conviction about that, because it's not life threatening. You pick out a teeth 3 days later, nothing's going to happen, no world is going to fall at their feet. Others, I think we're doing a disservice to them because they clearly have a tooth trigger, and that's what all of us know.
Most of the times,
and
yes.
V2 is from the upper, this one is from the lower, and it goes on like that. So I think that's a very important thing for them to understand what's going on. So now that we know that trigeminal neuralgia is the diagnosis, what causes trigeminal? You said some irritation nerve, this, that, this. How do you know what's going on inside, and how do you diagnose it, and what are the possible usual common causes that causes trigeminal neuralgia?
So trigeminal neuralgia, as we all know, is a clinical diagnosis.
Correct.
We make that diagnosis based on the particular history. And most of the time, they will give us a very classical history.
Correct.
Acute episodes of shooting pain in one or two segments of the face. Once we know clinically that we are dealing with trigeminal neuralgia, I think the investigation of choice is an MRI, is imaging the brain.
Got
So we do an MRI scan and look at a particular sequence where we look for compression of the nerve at its root with either an artery or a vein. And many a times you could have an MRI showing there is compression, but it need not be clinically significant. If you take a normal MRI, if you take my MRI, for example, I may not have trigeminal neuralgia, but I could have a nice artery sitting over my nerve, right? So the root cause effect may not always be true, but it has to be done, right?
You said very casually a particular sequence. Now, you know that that particular sequence is not even asked for
Many times
by the general doctor
absolutely
who doesn't understand the science of trigeminal
trigeminal
neuralgia.
neuralgia.
Again, it comes back to the same story. If he goes to a doctor outside who doesn't understand trigeminal neuralgia and the nuances connected with that, he will write MRI brain plain. And that guy at the diagnostic center, MRI brain, they'll bill, they'll do.
That's it.
Nobody is asking him whether they write a diagnosis or not. Nobody is asking him why don't you recommend this sequence. Nobody's operating.
Absolutely.
Everybody's operating at the cauda equina level or pudendal level or wherever it is. I can't understand because nobody's contributing to, somebody could have. It's like the dentist pulling out the teeth. See, the people are around available anyway. So what you're trying to tell me is, which I have seen many times, they come with an MRI scan, that's normal. Then I say, you need to do this sequence again. So, matte MRI na, they're upset that for whatever reason, because a lot of patients are claustrophobic.
Absolutely.
Getting into the damn machine, and the world has not been able to solve this problem. And they are pissed off with whoever it is that, to go back to that tunnel again to see what's going on. But what is that sequence that you're talking about?
So this is called CISS sequence, called a CIS sequence.
CIS sequence.
We usually ask it when we are dealing with the patient with trigeminal neuralgia, because that's the sequence that will clearly pick up whether there is neurovascular compression.
It's called a neurovascular conflict is what we say.
Right.
That's right.
The other rare causes, for example, you could not have a neurovascular conflict even if you've got a CIS sequencing done, in which case we call it the idiopathic trigeminal neuralgia.
Correct.
Right. To the lay people, it may sound like the doctor is an idiot and the patient's condition is pathetic, so we call it idiopathic. But no.
I didn't realize what you were trying to say. I was thinking, what is he trying to say? Where is he getting at? That's a nice one.
That's the usual definition of idiopathic, right?
Why I'm 25
the
years.
patient's condition is pathetic and the doctor is an idiot. He hasn't been able to figure that out. But yeah, that's the cause. That's one of the reasons. I mean, that we see it quite often, where there is no neurovascular compression or a conflict. You could have rare cases like multiple sclerosis, where there is damage to a segment of the nerve called demyelination, also contributing to compression. Very rarely there could be brain tumors.
Correct. I was just going to say that. Yeah.
Tumors that are directly causing compression on the nerve or in any part of the nerve, causing the neuralgic
Absolutely.
pain. But more often than not, we either see it as either the idiopathic version or the patients with neurovascular conflict. But an MRI brain gives us a lot of answers.
Got it.
Right? Because the treatment, if there is a neurovascular conflict, as you know, is different. If there is no compression, it's different. If there is a demyelination or a damage to the nerve, is completely different. So depending upon what we see is what we take it forward with.
So if I'm trying to understand what you're saying and put it to perspective for our audience, you're saying that the trigeminal neuralgia, which is the pain coming from the fifth cranial nerve, is the effect and not the cause. And you're doing an MRI to see the cause of this effect. And the cause could be something sitting on the nerve in the brain that is causing this irritation.
Correct.
If it is there, then we call it a neurovascular conflict. If nothing is there, we call it idiopathic. And we also want to do the MRI to make sure that we are not missing a brain tumor or something else, which then has to be treated primarily. Whether the neuralgia goes away or not is secondary, but we need to treat that first. And one of the commonest brain tumors, two of the things that we operate with trigeminal neuralgia, one is obviously trigeminal schwannoma that comes in. Second one is an epidermoid.
Correct.
The epidermoid also causes a lot of pain. Because of the irritation of the chemical stuff that goes on. So that's very important. So all in all, we see many patients, I'm quite sure you agree with me, that who are already on trigeminal neuralgia treatment without an MRI.
Absolutely.
And that's a sin.
That's a sin. In today's age and world, with technological advancement,
Yes,
there is no scope for that.
there's no scope. You know, it's
Absolutely.
like looking at your face and say, your blood sugar seems to be 250. Let me give you insulin. Correct? No.
True, very true.
Which physician is going to do that? Is a sin. I can look at your face and say, your blood sugar, your blood pressure seems, sir, BP jasti agad, sir, they come to me. What BP jasti agad means? He's shouting. He gets angry. For our people, getting angry means BP is more. I said, really? I said, where is the BP? What's going on? He's like that.
Then I should have a continuous monitoring on all the time.
Yeah, you have to put so it's like that. So that means to say that people, you know, in this age of evidence-based science
Medicine.
and things like that, you
True.
can't be doing all this nonsense
Absolutely.
and hocus pocus and things
Absolutely.
like this. So MRI is definitely a starting point. In the
Absolutely.
brain tumors, we may need a contrast scan, and then no question that can't be called normal without doing a cyst sequence.
Sequence.
These are the fundamental starting points. One more thing that will also causes trigeminal neuralgia symptoms is herpes.
That's true.
So do you want to tell our viewers a little bit about how herpes zoster causes this and what do you think about that?
So herpes zoster is just reactivation of chickenpox. All of us in our childhood or early adulthood may have had chickenpox. So the virus doesn't go away. It goes and sits in a particular portion of your spinal cord called the dorsal root ganglia.
Correct.
When later on in life, you may be going through some form of stress. And by stress, I don't mean personal stress. I'm not talking for divorce or alimony situation like that. But I'm talking of, let's say, a cancer or chemotherapy
or even a COVID,
for example, right? Anything that stresses your body reactivates this virus. Once this virus gets reactivated, the virus starts spreading along the nerve where the ganglia where the virus was situated. And this causes eruptions on the face.
Like chickenpox.
Absolutely. It looks identical chickenpox, but it is chickenpox is generalized.
Correct.
This is along a particular area.
So that's why it comes like a line.
So it could happen on your face, it could happen on your chest, abdomen, groin, anywhere. Now, when it happens on the face, we call it herpetic trigeminal neuralgia because it is affecting one of the three branches of the face.
Correct.
Again, an extremely painful condition. It's traumatic for the patients who are going through that pain.
I agree because my wife had it, you know, the one on the V2 division, and it was so painful. First of all, it didn't come on the face.
Absolutely.
She got the blisters in her mouth. And you cannot imagine, and she could not even swallow her own saliva.
Absolutely.
It was that painful. And I just couldn't imagine seeing her in that pain.
Absolutely. It's very painful. And, unlike in trigeminal neuralgia, where we somehow herpetic neuralgia is a little resistant to even medications, right?
I know.
So many of the time we land up using strong narcotics to bring down the pain, which is not something that we do very often in trigeminal neuralgia.
I think that's why there's a subset of doctors who think that treating the the herpes very effectively and very early is very important to prevent the damage that the virus does to the nerve. Because that the more severe the damage, more the neuralgia. Yeah, the neuralgia and that neuralgia, like you said, resistant to treatment and doesn't come and go away. Sometimes it lasts for many hours.
Many hours together, many months. And then it's, they can't even tolerate a little bit of air blowing on their face.
Yeah, they say that, just a fan air.
Absolutely. The fan makes their life miserable.
Miserable.
Yeah, and we had a elderly gentleman, not me, my colleague, who had this herpetic neuralgia on the chest. And it was so bad. She told me this, and that when he came to her, it was 4 years since he had the neuralgia. And for 4 years, he never wore a shirt or a bunion. He would be bare-chested.
Really?
Irrespective of the weather condition.
My
Summer,
goodness.
winter. For 4 years, he never hugged his grandchildren.
My goodness.
Right? And so when she did the block for him, the first thing he did is went and hugged his grandchildren because his pain came down.
Amazing. I mean, what a
Which is such a moving story.
I agree. Imagine.
I
mean, people are craving for these things. And like we have a dialogue in Kannada, Halidon kadle idon halilla, they say, it's like that at the end of the day. No, really, people do not realize that pain can be such a devastating thing. And only those who go through it and those who see them go through it really realize the impact of that whole thing. So, just to add to the herpes, because people are talking about the herpes zoster virus. So, varicella zoster is the name of the virus, and varicella is chickenpox and zoster is herpes. So, it's one disease that causes both. So, if you don't get chickenpox, you can never get herpes.
No, you have
So
to have a chickenpox certificate.
that's why you should get the chickenpox vaccine. Now, unfortunately, the chickenpox vaccine is not still the part of the government's, I think, the vaccination program.
I
Now
think
it
they
started.
have. They
That's
have.
what, for when we were kids,
Yeah,
it was
true.
not there. It
But
was
not that-
optional then. Now they've
Absolutely.
added
Now
it.
they've added mandatory.
Yeah, because of which many of you who are our age or before this came in, if you have had the vaccine, I think it's still good to have the vaccine
Yes,
because
so there is a
so that you don't get the chickenpox, and if you don't get the chickenpox, you don't get the zoster. So it's a double, thing at the end of the day. There's just a little bit of trivia bits, small stuff at the end of the day.
no, even patients with, I mean, elderly patients, we do recommend that they take
They
the
take the
herpes
vaccine.
vaccine,
Yeah.
irrespective of if they've had the chickenpox.
Oh, even if they've had, you recommend?
Yes,
Oh,
we
I
do
didn't know
recommend.
that.
Elderly patients, we do.
I
Or
see.
if you've had someone in your family who's had a zoster, then the spouse or the caretaker is recommended to take the herpes zoster vaccine.
That's another good message for you. So it's still thing to do. So please ask, don't take it yourself. So don't say, Dr. Sharan, Dr. Sadasivan Iyer told on the, podcast should give it and give me the vaccine. That's not what we're trying to say. Please ask your doctor, your physician, whoever you consult, and if he also agrees, I think it's definitely worth exploring. So trigeminal neuralgia. So we come back to the conversation that we have diagnosed the trigeminal neuralgia. We have imaged him. We realize that it's either idiopathic or it has a neurovascular conflict. Now, if neurovascular conflict is there, obviously they come to us and then we have. So what happens is normally, the nerve is exiting from the brain and coming into the face, and there's a blood vessel that's sitting on top of that. Every time it pulsates, that nerve starts getting damaged, and every nerve has an insulation around it, like how our wires have an insulation. And because that insulation gets damaged, especially at some place called the root entry zone, so that's where it is. So because of that, that can become like a jum sensation or a hypersensitive nerve root. But some people who are unfit for surgery, or those who don't want surgery, or who do not have the neurovascular conflict convincingly, these are the people and we need to start them on medications or anywhere else. So what are the medications? Are there good medicines available? Can the patients really get some good relief with just tablets? Is that possible?
So 80% trigeminal neuralgia all over the world is primarily controlled with medications alone, right? So there is the drug of choice we call carbamazepine,
Correct.
Which is a wonder drug. It was initially when it was introduced, it was as an anti-epileptic medication.
Correct.
But it works wonders in trigeminal neuralgia.
I agree.
You would agree with me.
I agree.
So a good dose of carbamazepine, which is usually a little bit of trial error, because what dose works best for you will take a little while to find out.
Yes, titrating
the dose. Yeah. So we titrate them over the 1 or 2 weeks, and by the end of the second week, most patients are able to have their pain under control. Now, carbamazepine is not a drug that is devoid of side effects, right?
Correct.
So as
any other medicine,
absolutely, as the dose goes up, the side effects also increases. Of all the side effects, we are worried about 2 major side effects. One is a very dangerous allergic reaction, called Stevens-Johnson syndrome, right? Which can potentially be life-threatening.
I agree.
When I was training back in Singapore, every patient had to undergo testing for a gene called HLA-B1502.
Oh, really?
Yeah. We had to.
I didn't know there was gene connected.
There was a gene connected, and every patient mandatorily had to undergo a testing for the presence of this allele.
Okay.
And if it was positive, we could not give the patient carbamazepine. We had to look at alternatives or second line drugs.
Even Oxcarb would be
absolutely no form of carbamazepine will be because he or she is very likely to develop a very dangerous form of Stevens-Johnson syndrome, which can be fatal.
I agree. We have seen some very closely dangerous stuff.
Yeah. So in India, we don't do that testing very often.
I have not heard of it, let me be honest. Yeah.
In Southeast Asian population, we are all very prone to the absence or this allele. So
what's called HLA-B?
HLA-B1502.
1502.
So
make a note.
Because of this absence, you are more likely to develop the side effects or the dangerous side effects. So that testing doesn't happen here very often. Very few patients. In fact, if you send it to a lab, they will send it back saying, "Sir, we don't have this here." So this is more of what you see. You just hope and pray that the patient doesn't develop anything. But we've had, I'm sure you've had patients who you put on carbamazepine, come back next day in the casualty with
Yeah, but sometimes if they come the next day, it's okay.
But
But this is idiosyncratic, which
absolutely.
means that it's not dose related,
Right,
it's not time related. They can come back even after 6 months.
6 months.
So sometimes we have to warn them that if you
Absolutely.
get this, please come back quickly, because sometimes they mistake it for a viral
Pustule
and then they get treated locally with an
absolutely.
antiviral, and then suddenly it flares up, and then there's
I'm
a
okay with
chaos.
the antiviral. They
Yeah,
Ayurvedic and homeopathic medicine, which
that's
makes it
true.
worse.
That's true. So that's quite dangerous. So yeah,
Dangerous.
so we
That
get that.
is
So
number
though it's good, what's the second side?
Second one is it can bring down your sodium levels. And
Correct.
that can happen with long-term intake.
True.
And the third most important side effect is it can reduce your white cell count.
Correct. Bone marrow.
Yeah, it can cause a little bit of bone marrow suppression.
Correct.
So any patient on carbamazepine is warned about a possible allergic reaction, and on a 3-monthly basis, we get their sodium levels done, we get their liver functions, and then we get their counts done to see if things are normal. If everything's fine, then and they are okay with taking carbamazepine, then also
I agree. I have patients who are taking
who've
for
been
many
years,
years, are
right?
doing very well. Yeah.
In the recent past, we've had better drugs than
Correct.
carbamazepine. We have oxcarbamazepine,
Correct.
we've had eslicarbazine, which have
Correct.
reduced the incidence of hyponatremia, low sodiums, and even the Steven Johnson syndrome, and better compliance. So you can take them once. So, for example, eslicarbazine is taken
Correct.
once a day.
That's
Right. So
even
you don't need
oxcarb you can take once.
oxcarb, yeah, but generally what we've seen is you require the
twice.
second dose.
That's right. That's right.
So that way the compliance can be improved. Apart from that, there are second line drugs like gabapentin, pregabalin, which we land up putting patients on if they are not able to tolerate carbamazepine or any of its derivative. There's baclofen, which you use for intrathecal use. We use it to break the pain spasms. So my prescription in a trigeminal neuralgia patient will always have an SOS baclofen, because that's first drug that breaks the spasm.
Interesting.
On medication, things are going fine. We let it be that way. Now, if they are not tolerating medicines or they have developed some dangerous side effect, then, and they are not in a position to undergo surgery for whatever reason, medical, non-medical, whatever reason, is there a middle path that can give them relief of pain?
Before I come to that, before you say that, I want to ask you one more question on management. So we also know that, just because they got pain relief today, it may not last the whole year.
Absolutely.
Is there a seasonal, breakthrough of these pains that you see in these patients, specifically so that you warn them, you increase the dose at a particular age? Is there anything like that you want?
So usually winters are culprits with respect to most nerve-related pains.
Correct.
Most of them aggravate in winter season.
Correct.
And the reason being that your nerves are a little more sensitive when it comes to cold.
Correct.
Which is why you see most doctors will tell you put hot compress.
Correct.
Right. So your nerves are sensitive, especially an irritated nerve is very sensitive to cold stimulus.
So
that's why when we do quantitative sensory examination in our patients, we use cold swab.
Correct.
Because it can pick up much faster.
I agree.
So seasonally, winters are worse, summers are better. They're very happy in summers, but they start dreading the presence of pain.
Some of them. That's when I told them to, sort of cover their face.
Absolutely. I tell them when you're going out, please cover your face. And, even when you get up in the morning, don't put cold water on your face. Wait for it to be a little warm. Don't drink cold water.
Ice cream.
Ice creams are a typical no, apart from the throat issues. This is one reason why we shouldn't give why we don't allow ice creams.
I think so that we have those things happen. So let us assume that somebody has taken the medicines. You said 80% of people get benefit with the medicines, and they're pain free for X amount of time. Is there a possibility that you may stop the medications in a subset of patients who've been so-called pain free? Is there something like a cure in trigeminal neuralgia?
I haven't had the guts to stop medication for anyone who's been on medical management alone, right? So I try keeping it to as low dose as possible, to what is tolerated, at the same time giving them some form of clinical relief.
Got it.
But yes, to answer your question, have I been able to do it? Take off medication? No. I'll be very honest with you.
Got it.
Unless there is a form of intervention done.
Got it.
As a family, we believe in Shankaracharya.
Correct.
We call him Jagat Guru.
Correct.
So my grandparents wanted to go and meet him and, take his blessings for my uncle. So they said, you come. As usual, I was the freebie. So
you went to Kanchipuram? Or?
So we went from Chennai to Kanchipuram with my grandparents. Okay. So I went there and took the blessings. He looked at me and said, Enna Pandara, which means what are you doing? I very casually told him, I've taken medical seat, but I'm going to do engineering. So there were two Shankaracharyas, the junior and the senior. So the junior looked at me and said, no, you take medicine. I said, no, my seat is not, it's not in a great medical college. Doesn't matter. You will get it in the choice, second round. Don't worry, you take. I didn't take it seriously. My grandparents, he has told, no, you should take. So we went to meet the senior Shankaracharya. He asked me the same question. What are you doing? I said, I've taken like this.
You thought it was match fixing?
I thought, how can he answer the same question? I said, but I'm not going to do. I'm going to do medical engineering. So no, you will get your seat in MS Ramaya.
He said that?
He said that. He said exactly the name of the college.
So now we are going to shift gears to go to the subset of 20% who either are not tolerating the medications because of which they continue to suffer the pain, or they're medically intractable. That means the medicines at optimal doses with the adequate number of doses have not benefited them, or they're having breakthrough pain which is affecting the quality of their life every single day. And they either it could be idiopathic when surgery is not an option, or it could be neurovascular conflict when they don't want the surgery for whatever reason, or they're unfit for surgery. So in that situation, as an intervention pain physician, what else you have in your toolkit that can help them get better? Because many patients, when they come to me suffering and somebody sends them to me and I send them to you, and they come back with a big smile on their face. They say, sir, why didn't my other doctor tell me that? That's the constant question. I'm quite sure you're asking the same question.
Yeah, true.
So for the larger audience, including the doctors who are listening to this, the general practitioners, what is this magical thing that you do that they should be aware of and they can refer patients to you?
So typically for long-lasting relief of pain, right? We do two commonly done procedures. One is a radiofrequency ablation.
What do you mean by a procedure? Is it a surgery? Is it like
no?
OPD?
It is not a surgery. It's a needle that is passed into or in the vicinity of any particular structure.
Okay.
Usually done under guidance.
Okay.
With or without sedation. Sometimes needing a general anesthetic. But there is no cut.
There is no cut.
We are not removing any portion of the body. We are not making absolutely no stitch. So this is what we call as a procedure.
Got it.
Now this procedure can be a little painful. You may tolerate it depending upon what your threshold for pain is.
But you do use local anesthesia.
We do use local anesthesia. When I'm saying you may tolerate it, there are a lot of patients, even with local, they will jump. So the sensitivity
I agree.
will
Very
differ individually. So we use these two procedures very commonly. One is a radiofrequency ablation. The other is a percutaneous balloon compression.
Got it.
Both use...
What is radiofrequency ablation? Can you give it in layman's terms so that our audience or not doctors understand?
So to a lot of my patients, I say laser surgery. I'm using the wrong word, but that's a very easy way to make them understand.
Got it.
So what we are doing is using electrical current and just burning that part of the nerve. We are thermocoagulating, what we call thermocoagulating.
The same thing I do in the brain.
We do in the brain,
too,
right?
for my guitar surgery that
absolutely.
I did.
So we do that for the peripheral nerve. So here we ablate the portion. So like I say, I always tell my patients, so the nerve is coming out of the brain. Before it reaches your face, it goes through a bus stop.
That's what I say.
The bus stop is called ganglia.
Got it.
Which is the seat of all troubles.
Correct.
Right? So what we do is we kind of ablate the nerve or that portion of the ganglia from which that nerve arises.
Correct.
Right? So we do that under X-ray guidance. Usually,
which means it happens in the OT more
absolutely, it happens in the theater. We use that and usually done under a minimal sedation. Usually admitted in the morning, sent back by evening.
Like a daycare.
It's like a daycare. Maybe stay overnight depending upon what time of the day you're doing it. But if an elderly patient, you have had to sedate, then you want to keep them overnight. But young guys, you do it earlier and send them.
Correct.
With a little bit of discomfort, which is fairly tolerable, can be managed with some IV sedation. And what we are doing is basically when you burn that nerve, you are replacing the sense of pain with a sense of numbness. But you would know better. A lot of patients will come and tell you, this numbness is far better than the nerve, the pain that I was going through.
And most of the numbness is not along the entire nerve.
It's a specific portion, right? It's a small portion on your face that becomes numb. And which is fairly tolerable. Initially when they go through it, first 3 days, first 4 weeks, it's a new feeling in the doctor, shave, I'm not able to feel that portion. So but that's comfortable because over a period of time, your brain tells you to live with it,
Correct.
which is the beauty of having your brain in order.
I agree.
So that is one procedure we do, and very, very effective procedure. Yeah, the only limitation of the of the radiofrequency is that we don't do it for trigeminal neuralgias in the V1 segment.
So, are you burning the whole nerve? Are you killing it? What are you doing? In a sense that will they lose other functions related to the nerve?
So it depends on which nerve we are doing. So if you're doing the V2, which is this portion of the brain, of the face, usually it's only a sensory loss, but will recover in 6 months' time.
Correct.
With a V3, because the V3 also supplies the jaw muscles,
Correct.
when you burn that, there could be a little difficulty in chewing on the side that is affected.
Got it.
But it's a very temporary,
Correct.
low level of difficulty,
Correct.
which can easily be managed by two things. Chew on the other side, easiest way. And the other thing is we tell them to chew a lot of bubble gum so that the muscles kind of strengthen up.
Got it.
By the end of the 3rd month, you will find when they come back for a follow-up, this is not a major complaint.
Got it. I agree with you.
Yeah,
Most of
so
them.
they're okay with that.
Yes, yeah. So what he's trying to say is that for V2 and V3 divisions of the trigeminal nerve, we can burn it and burn these, the part of the nerve that controls the pain, because of which he has good benefit from pain. And most of the side effects they have is temporary, and most of it is manageable. And how many years are they pain free? What's your experience over time between you and your seniors and everything else that you have seen?
So I've had patients who've been pain free for as long as 8-10 years.
Fantastic.
But I've also had patients who've come back after a year of.
Yeah, because it's very relative.
Very
We can't predict what is going
and
on.
we really don't know if the nerve in entirety has been burned. We're just using guidance there. But usually when we say a well done radiofrequency gives relief anywhere between 2 to 5 years.
2 to 5 years.
I'll be very honest and realistic.
But we can do it again.
Absolutely. It can be done any number of times.
So that's the hope it is.
The repeatability is
So 2 things we are trying to communicate with this. Number 1, there's no cure for this. You have to endure it all your life as far as the disease is concerned, but the pain can be managed very effectively between medications and the radiofrequency ablation. That can be done many, many times if necessary. Now, a follow-up question to this. You are going in with imaging, but how do you know you got the V2 or the V3? Is there any signs any techniques that you follow?
So when we put in the needle, we also put in a small, like a wire along with the needle, and that is connected to a machine, which gives us a little bit of electricity.
Correct.
So when you stimulate the nerve, you are stimulating the exact area of pathology. So if a guy has a V3 neuralgia, we stimulate that portion of the nerve. So we give in a little bit of electric current, and then he will end up saying, yes, sir, that's where I have the pain.
So you map it.
We do an electrical mapping. And then so
it's
we
not
know
a blind. It's not a blind.
It's not a blind procedure.
Yeah, that's what I want the audience to
I'm not poking them.
Yeah. Right, it looks blind because he's going in, but he's got an image guidance. He's got an electrophysiological guidance.
Absolutely.
And between the two of them, he makes sure that, and then we have the third feedback from the patient, which is why he's awake.
Absolutely.
And he tells you exactly what's going on, and then we make sure that we do the right thing by burning, and that makes a difference. So that's good. So we have got the V2, V3 sorted out. Now you are trying to say something different for V1. Why can't I use the radiofrequency treatment for V1? What are the risks, and what else do you do because you can't do this?
So the V1 nerve, which is the ophthalmic division that goes here
around the eye,
also supplies a portion of the eye called cornea.
Correct.
Which is the transparent portion covering the iris, or the black portion of the eye. And the cornea is a very sensitive structure.
Correct.
We don't want. So the nerve that goes in to supply the cornea comes in from the ophthalmic division.
Correct.
Now when you
which is V1.
Which when you ablate the nerve or you burn the nerve off, you are making it insensate. You're making that particular portion insensate.
Correct.
Now, insensating the cornea is not going to affect your vision. Right? You can still see.
Correct.
But it will predispose you to develop infections, irritations, and tears in the cornea, which can then result in some form of blindness.
Correct.
So because the ophthalmic division supplies the cornea, we do not ablate that portion of the nerve. But we should be able to give some form of relief.
True.
So what we do is that we do a procedure called a percutaneous balloon compression.
Okay.
So what we're doing in a PBC is a little different. In a radiofrequency, the patient is awake. Here we put the patients to sleep for two reasons. One, the needle going in is a little thicker, so it's difficult to do it under local. Two, and then once we put in a needle, we put through the needle we put in a catheter, which a lot of vascular surgeons use to remove clots, embolectomy catheters. Correct. And this again done under guidance. And this balloon, the catheter, when it reaches the particular area in near the nerve, with X-ray guidance, we inflate. There's a balloon attached to the small catheter. Yeah. So when we inflate the balloon, the nerve gets destroyed. It's a mechanical compression. I don't want to use the word destroyed, but compressed against the underlying bone and the balloon.
Between the bone and the balloon.
So that causes a break in or interruptions of signals.
Okay.
Now we all have two types of fibers. We have the A beta fibers and the A delta fibers.
In the nerves.
The A beta fibers are the ones responsible for transmission of touch and sensation. The A delta and C fibers transmit pain.
Correct.
The A beta fibers are thicker. The A delta and A C fibers are smaller.
Correct.
So when you compress the nerve, preferentially the A delta and C fibers gets compressed. The A beta fibers being thicker are spared. And because they don't transmit pain, you have relief of pain because of A delta C fiber compression. But at the same time, your touch sensation is kept intact.
That's why I said in one of my previous podcasts that God has designed this human body for surgeons or people like us. It's just amazing. How, if you go into the details of how beautifully it's constructed, how we as human beings have understood this and differentially, preferentially how to manage all of these things to get the right benefit for the patient and minimizing the collateral damage, as what you can say.
Absolutely.
So that was quite a heavy discussion on trigeminal neuralgia, and I think it was very valuable because most people don't know about it and things like that. But before I go into the next topic, you said, did you want to be a doctor from a childhood, or what's your story? See, I had a story. I want to be a doctor from 8th standard because of something that happened. What's your story?
So I've always wanted to ape my cousin, my elder cousin, who was a superstar of the family. So I wanted to do basically whatever he did. So he did well. He did his +2, and then he went into one of the best colleges in Mumbai. He did his engineering, and then
he's an engineer.
He's no more with us.
Okay, sorry to hear that.
He did his engineering, and then we heard of this term called campus placement. And then his salary was mind-boggling when he came out. So I said, yeah, this is life. This has to be
This is it.
This is it, At 25, he was earning, truckloads of money.
I can imagine.
And then, so I basically wanted to ape him. So I did my 10th. My mom forced me to take biology as a stream. I was very happy doing electronics, but she forced me into taking biology. She said, why do you want to give up? You keep that as an option.
So your mother had a scheme.
My mother...
I should meet her and ask her this question.
And I think she forethought the whole thing.
Looks like it. Every mother is like that. There's something going on.
Yeah. So they know what's going on.
What's going on.
So at the end of 12th, I did fairly well in both streams. Then I attended that counseling. Took
CET counseling.
CET counseling. I took a seat for namesake. I said, I'm just going to attend the counseling.
You took what seat?
I took a medical seat in one of the medical colleges in the city. I was a decent rank. So I came out, not impressed one bit. My family was celebrating. My mother was in tears. But it's okay. Because I knew I'm not going to continue.
Oh, you were clear even then?
I was clear. I just went because my mom was forcing me to go for the counseling.
Got it. Okay.
That evening, we got a news that my uncle suffered a heart attack.
Oh.
And he was in Chennai.
Okay.
So we are close. So we flew down. Because my cousin, who's
same person,
he was in US at that time. So somebody needed to be there. So me, dad and mom flew down to Chennai. And when we went there, he had to undergo a bypass.
Okay.
So, when between 12th and starting your professional career, there is almost 5-6 month gap. So the only jobless person in the family was me.
Unemployed.
So unemployed. I had to stay back. So I lived with my uncle in Apollo Hospital for 1.5 months. I lived there because I was taking care of him.
Correct. You were a caretaker. Whatever.
So then my grandparents, who were 80 plus, they also flew down, saw him. And they, as a family, we believe in Shankaracharya.
Correct.
We call him Jagat Guru.
Correct.
So my grandparents wanted to go and meet him and, take his blessings from my uncle.
Mm.
So they said, you come. As usual, I was the freebie. So,
Where you
sent.
went to Kanchipuram or?
So we went from Chennai to Kanchipuram with my
Okay.
grandparents.
Okay.
So I went there and took the blessings. He looked at me and said, Enna pandra, which means what are you doing? I very casually told him, I've taken medical seat, but I'm going to do engineering. So there were two Shankaracharyas, the junior and the senior. So the junior looked at me and said, no, you take medicine. I said, no, my seat is not, it's not in a great medical college. Doesn't matter. You will get it in the choice second round. Don't worry, you take. I didn't take it seriously. My grandparents, he has told, no, you should take. So we went to meet the senior Shankaracharya. He asked me the same question. What are you doing? I said, I've taken like this.
You thought it was match fixing?
I thought, how can he answer the same question? I said, but I'm not going to do. I'm going to do medical engineering. I said, no, you will get your seat in MS Ramaya.
He said that?
He said that. He said exactly the name of the college. He said, you will get your MBBS seat in MS Ramaya. You will take it.
My goodness.
And then that 1.5 months that I spent in Apollo, I saw doctors very closely. And something in me said, maybe this is not a bad option. Sure enough, second round counseling. I got the
MS Ramaya?
MS Ramaya.
I think
merit seat in MS Ramaya.
Amazing.
So
spiritual WhatsApping.
Maybe there is a
spiritual WhatsApping.
Spiritual connect to it.
Of course.
And then I went back after about a month of doing MBBS. I went back and told them.
Amazing.
That, this is what happened and your prophecy actually came true.
No question. But I think I also believe a lot in these things.
So that's the journey of my entering the medical field.
Interesting.
So the only person who cried when the engineering seat was given up was me. The entire family was overjoyed. But yeah, that was it.
Fantastic. So you got into the whole process. Then what happened? What made it choose anesthesia?
Anesthesia was, most people who do anesthesia do it because they want to get into critical care.
Okay.
So I was no different.
Okay.
I got a decent rank, didn't crack internal medicine, got anesthesia. And
you didn't want to be a surgeon?
No, I was very clear. My surgical skills were... I knew I was not made up for it.
Made for it.
So anesthesia was a decent bargain. And I heard a lot about one professor called Dr. Ramkumar.
Correct.
And the whole world kept talking. Wherever you go meet, where are you doing MD from? I said, KMC Manipal. Oh, Dr. Ramkumar is there. So I took up anesthesia because I heard so much about him.
Interesting.
With the intention of coming back to medicine in second round. But the 1 month I spent there made me realize that this is not a bad field. Because I saw a lot of things that they were able to do. It was a good trade-off between becoming a surgeon versus being a physician. So I liked it.
A little bit of both.
A little bit of both, right? And we're very clear in what we want.
Correct.
And no frills about...
True. Yeah. Very true.
Anything. So that was my foray into anesthesia. Once I finished anesthesia, I was very clear I wanted to be a regional anesthetist, which means to do nerve blocks.
Correct.
So I worked in Sparsh where I learned a lot about nerve blocks and my training. And then I thought, if you can give a nerve block, you can be a pain physician. That was my understanding.
Okay. Correct. Theoretically true.
Theoretically, yes.
True.
You do a nerve block, you're a pain physician.
Yes, I agree.
Everybody does that. Till I met 3 people. One was, of course, you. The other 2 were Dr. Hira and Dr. Raghavendra, whom you worked with as well.
Of course.
And they taught me the
great
importance.
Guys, both of them
Absolutely.
Great guys, yeah.
And they taught me the importance of looking at a patient beyond a procedure.
Wow.
Yep.
See the patient beyond the procedure.
Beyond the procedure.
I think that's a great message.
So
great phrase.
From there on, then I decided, I was doing all, you attend a couple of workshops, you get proficient with. I was doing all of that. Till one day I had a patient whom I had done a procedure for, came back to me and in front of my OPD like this. Said, Doc, I know you did the injection, but it didn't work. And I didn't know what to do beyond that. That's when I decided, if I'm sitting in this chair, I should do justice. So that's when I felt, I should get trained further. Then with Dr. Raghavendra's help, I applied to Singapore.
He also trained in the
Absolutely. He trained, and one email from him changed everything. So I owe a lot in my life to Dr. Raghavendra. So, and then I went there. And the perspective there was completely different.
I know.
You know how it is, when you go abroad, the training, the perspective that you get.
Absolutely. The mind expands so much.
So
it's just
much. You see a lot of things.
Yeah.
So I always recommend a lot of my junior colleagues also. I said, you go abroad for a year.
I agree.
Come back.
Yes.
You don't like the place, you come back. But it will open your mind to a lot of possibilities.
True. I agree. I agree with you. I completely agree with you. Just to add, Raghavendra, I was clear. See, we as neurosurgeons see a lot of pain.
Absolutely.
Neck pain, back pain, headache, all of those things. And I also know that most of that we do is symptomatic treatment. In fact, I tell my patient, which I am asking symptoms, let me be honest. But I believe that allopathy medicine is great for emergency, surgery, critical care. But these chronic things, we have so much of gaps in what we offer to what needs to be offered to patients. So then when I started digging beyond the prescriptive medicines that I was giving, that's when I got sort of introduced to pain medicine somewhere in the early 2000s. Then I also realized that the intervention pain physician, most of them anesthetists. So any anesthetist who would work with me, I would say, boss, you go and train, I will fund you.
True.
You please go and come, because there's so many people in India who needs this. And like you said, you have to have a thing, either you have it or you don't have it. That's the bottom line. There's nothing in between. So most of them are not keen, either they didn't know about it, or not keen, or whatever it is. And until I met Raghavendra sometime in, I think, 2011, 2012. And this guy had just come back from Singapore, and he was looking for pain practice, and nobody here in Bangalore even understood pain practice. And somebody said, they told him. So he got it frustrated because he didn't have a job. He went and joined anesthesia. And he joined a corporate cancer hospital in Bangalore. He was working there, very dejected, but he was working for whatever it is. Then he met a colleague anesthetist who was one of those guys I was trying to motivate to go, who had not gone. Raghunandan, his name is. So he and Raghu were colleagues, and they were talking in the in the OT complex. And Raghavendra said, like, they say, I'm pain physician, I'm doing anesthesia, I'm not doing chronic pain. Raghu said, the only fellow who can help you is go to Dr. Sharan. And that's how he came to me, and that's how our partnership went. And for me, I'm telling you, I was already a conservative spine surgeon, which we will talk a little later. But my spine surgery came down 50%. Just because I understood that the pain generators were not all what the scan showed.
Absolutely.
And for me, that was transformative. And I think I have never looked back from then. And I was clear that I have to have a pain physician in my practice so that I do justice to my patients. So that is where my thing. And then obviously Hira came in, and then we met a team, and then you showed up, and we were trying to do what it is, but it was still fledgling, and that's what it is. So you were continuing on your journey as a pain physician. Then what happened?
So, when I came back, I thought I will be the most sought after.
Welcome with a garland, like how someone, like the Indian cricket team won the World Cup. But
so that's that's honestly the feeling that I came back with, only to be shown a very harsh picture where people, your fellow colleagues, don't know what it is to do pain medicine. Your patients are a different ball game altogether. We haven't even reached the patient, but your colleagues who don't understand what you're doing. So then, trying to meet up, trying to tell them what we're doing. And then slowly but surely things have picked up. And it is, I think, God sent that I also met someone like you who understood what it is.
Correct.
And then took it to a different level.
I have loved working with you, let me be honest.
Thank you, sir. Mutually the same.
Yeah, because I think the number of patients we have jointly served with very minimal things, and when I say go to him, he's going to fix it, and especially he'll do it right away. They're even happy because there was like suffering, and many people really see back, and the fact that you are kind enough to do it immediately and things like, which is not you don't put up your price and say, like this, like that. You can always step it up and make it look more complicated than what it actually is.
True.
Which doesn't happen. So that's that's great to know that you're finally in this and we are working together. And
what I also realized in the last few years is there are a lot of complex problems with extremely simple solutions. The problem
supposedly complex, correct?
Absolutely. I mean, supposedly complex. Complex by what? The solution is very simple.
I agree.
Right? And then you can just, when you have the means and the access to solve it immediately, why do we have to make life difficult for the patient who's coming in?
I agree.
Right. So,
but I heard from somebody that you do black magic and all that. What's that story all about? Huh? So educate us about what kind of black magic do you do?
I'm more than happy to tell you that story. So in my OPD, there is a model of skull because we see a lot of patients with trigeminal. So I have a skull model to explain where the needle goes. There is a knee model. There is a spine model. So there was a patient who had come in with another relative for something else, but he was sitting near the OPD and he was observing this. And I kept going back and forth between the skull, the spine, and the knee, those bones. So he came in, and I'm sitting in my OPD, very well dressed with a tie and an apron. So he knocked on the door and said, "Doctor, are you?" The first question. Didn't even say doctor. "You're a doctor?" I said, "Yeah."
And this is in Manipal Hospital, huh?
No, this was not in Manipal.
Okay.
Fortunately, not in Manipal. So he came to me and said, "Are you a doctor?" I said, "Yeah." "MBBS doctor?" I said, "Yeah." "No, you do black magic?" So I was a little flabbergasted. Why is he asking me about black magic? "No, I saw somewhere pain management and you have skull, bone." And so,
the usual,
those ones. So I
skull with those two
those
things
two
like
crosses
this.
there.
Phantom comes, yeah.
So for a second I was angry, but then I was able to see the funny side of the whole thing.
Correct.
So wherever
Amazing how people perceive
this.
I know.
So unfortunately, it's the legacy that is carried on. Anyone, I mean, if you had intractable pain, I still know patients who are taken to these.
Yeah, because they don't
black
know
magic
people like us are available who do these things, and so that's one of the goals of this podcast.
Curry leaves sit on the head,
Yeah.
and all sorts of things done.
It's amazing.
It happens even in cancer pain, you won't believe.
Oh, thanks for saying cancer pain. So I think we'll now shift track to cancer pain. I know cancer pain management is very close to you. I can see that twinkle in your eyes every time. Raghavendra used to have the same thing, cancer and palliative care. So tell me, what makes somebody like you look at such suffering cancer patients? What takes you to them? Because cancer is such a difficult, set of problems to do, so varied. They've gone through so much. So what makes you foray into that field? Because it's not easy for everybody to get into the space.
Sir, what I have seen is cancer pain causes the most suffering.
More than the cancer itself?
More than the cancer in itself.
Really?
Because the suffering is not borne by the patient alone. It is borne by the family. It is borne by people who care for that person, the friends, the well-wishers. It's a very emotional, there's a lot of emotional component to that, right?
Because they think the cancer sorted out, something new has come.
Something else has come.
Yeah.
Many a times, like you correctly said, the cancer is completely sorted out. But
yet the quality of
life is so poor. Many a times the quality of life is poor because they are unable to afford, because they've burnt out the treatment. Many a times, a lot of palliative care patients, when the oncologist says no further chemo, go to Ayurvedic doctors, homeopathic doctors, or some have gone to the village doctor. And the worst I've seen is an oral cancer patient from the village, didn't have money to continue treatment, went to this so-called village, not a doctor, but one of those physicians in the village, who told her to apply dung of the cow every day on the face as a treatment. This lady diligently did this for 45 days.
45
days. Came back a month after the 45 days was over, hoping that the cure will, but came back with extremely foul smelling fistula, which had eroded her face, exposed her jaw. And, what can you do at that point of time?
Crazy.
No surgery is possible. And what do you do with that point?
Crazy.
So that's where, your heart goes out to such people.
I can imagine.
A lot of my patients till today ask me, "Doctor, there is no cure. Can we try Ayurveda? Can we try homeopathy?" What do you tell them? They want to cling to that ray of hope.
I agree. They want to appear to be.
They want to be. Even if they may not understand that this is going to be cured, they want to believe that there is something curing them.
Correct.
Hope. Very beautiful word. Hope.
True.
If there is hope, then everything else goes. The moment that hope goes, it's a problem. So what we do when we treat patients with cancer is give them that hope. Many of the times when they say no chemo, they understand it as no treatment. So the first thing that we tell them is your treatment isn't over. We are also providing you treatment. But the goal of treatment, which was to cure cancer, has now shifted to keeping you comfortable. And that is treatment. There is a science behind that.
Correct.
There is a logic behind that. There is a sequence with which we do things. And that is not directed only to the patient. It is directed to the family of the patient, to the caregivers.
Very nice. I think they are the ones who are actually going through a different journey.
set of
Like we see that in neuro also.
Absolutely.
Yeah.
When you see patients with stroke,
Yeah,
it's not
yeah,
only the patient who's
agreed.
suffering.
The patient has a journey, the family has a different journey.
Completely different
Completely
journey.
different journey.
Absolutely.
Completely different journey.
And to be able to integrate these two journeys
Very critical.
is extremely critical.
And yet very few organizations doing. I'm so happy that you are, but that is actually a lot of dirty work, if I can use that word. I'm honest, because no, in the sense when I say dirty, I'm using it responsibly, because what I mean is everybody is so much into this money, going here, going there, doing this, doing that. Some, to spend that time empathetically to understand somebody is a very different, beyond the call of duty, as what we say at the end of the day. So what do you do for this cancer pain patients or patients with cancer pain? Can you just give us so that if there's somebody with cancer pain survivor who's struggling, he will be able to.
So most of the time, it is a good hearing of what they're going through. Because if you talk to any either cancer survivor or a long-term cancer patient, the first thing they will tell you is nobody has listened to what I'm going through. People will look at the scan. People will look at the report. People will look at the molecular report. But I want to be heard out. So many a times it is basically hearing them out and listening to their problems. And a lot of them feel better after that.
Half counselor's job.
Half counselor's job.
Yeah.
I'll tell you a very funny anecdote about a counselor. So I was talking to a patient about her needing counseling
for
cancer. For cancer pain. Very recently. She kept saying, he didn't seem to be interested in that. She was very active when I told her about medicines and injections. I said, no, you also need doctor counseling. Which means he said, you do it yourself. Why do you want to send me to a counselor? So yeah, so
I love these patients because Papa, they come with something, they like you, and and when we land up doing it also, because sometimes
what
they
just
to do?
Can't help it. So that kind of so we do a lot of counseling. We treat them with many a times their analgesic doses are not optimized. Right. Correct. That can stem in from the patient's fear in itself. He would have survived cancer, but he's very worried if he takes that extra paracetamol, his liver will fail or kidney will fail. Correct. If I take this, I said, why not? So many times they don't follow prescription. You give them a paracetamol 3 times, they will take it once a day. My pain is not gone. Why? I didn't take this medicine. Why? ಜಾಸ್ತಿ ತಗೊಂಡ್ರೆ kidney fail ಆಗ್ಬಿಡುತ್ತೆ. This kidney fail. Somebody has told. Correct. Somebody has told. Kidney failure.
It's not that it's not without substance.
No, absolutely. But you have to use it in the context.
Exactly.
Right? So what I try telling them is, first and foremost, we always optimize analgesic dosages. Many a times.
So your analgesic is non-steroidal NSAIDs or combination?
Combination of narcotics. In narcotics, when we say we use strong narcotics, weak narcotics, depending upon what the pain of the patient is. This is not a one formula fits all approach. So we use a combination. And another thing that I tell them is, especially in cancer pain, there is no one magic pill that will cure your problems.
Very true.
There is a subset of medicine. Doctor, you have written 6 tablets. I cannot take so much. So you try telling them that, each one works at a different possible angle. And you will need a combination of medication.
No, actually, just to add here, see, whenever I write a prescription, I turn it around. And I tell them, this is for this is for this. The moment you make them understand that,
True.
I think the buy-in is very good and the compliance is even better. Because they understand that my doctor has heard me. He has understood my problem.
Absolutely.
He has given me a prescription specific to that.
For these
if I take it, I'll get better. I think that psychology is as critical as swallowing the tablet.
Absolutely.
And then that belief, that energy, I think it creates the magic.
But Sharan sir, when you have 30 patients to see in your OPD, is it realistically possible that you can explain every tablet, every side effect that it possibly can to all your patients?
I mean, fortunately or unfortunately, I don't have the problem that you're having of seeing 30 patients.
It's not like I have a problem.
No, I know, but so I try to make sure that I do this, because eventually they come to us with some direction that they need. And many times I see the psychological impact is more than the physical impact of what they're going through.
Absolutely.
And that is actually killing them every day rather than doing anything. Like, I'll give you a simple example, spondylosis. You know how abused this word is. Migraine and spondylosis are 2 most abused words.
True.
And I remember one 35-year-old guy came and sat in front of me, very depressed, looking very down. And I said, what's your problem? Sir, spondylosis. And he was like, I said, you're talking as if you're terminal stage of cancer. And he looked at me like this. I said, boss, this is spondylosis. It's just wear until you go to hell with that. What's your problem? At the end of the consultation, he was so gung-ho that he got his life back. I
Back.
did nothing except
True.
telling him that I demystified this damn word plus
Absolutely.
spondylus. So what happens is so many times people misread it because of whatever this Googleitis or whatever you call Dr. Google or whatever.
Dr. Google, Miss
Ah.
Wikipedia.
So you write it, you'll die with any of these damn problems. They're so depressed when they come to us. So I'm telling you guys, many of these things are so easy to manage, and half of it is upstairs and not downstairs problem at the end of the day. So it's like
You use the right word, sir. Demystify.
Yeah.
Many a times the consultation is just about demystifying myths.
Make it real, no?
Absolutely.
I said, that's all it is. So they come back with an MRI report, such a long list of impressions. And I said, no. So yeah, so many things. I said, everywhere they have written, what am I going to do for that? You have this. You can't imagine how it goes. There was a doctor, senior doctor who used to work in Kidwai Hospital, post-retirement, walks into my outpatient with back pain. Okay. And then I look at him, I listen to him and everything else. And I finally asked him, how did you find me? Because, he didn't say,
Correct.
Sir, I searched on Google for you. I said, here's a doctor who has used Google to find me. I mean, good and bad about it. And then I finished everything. I explained to him exactly what is going on, what needs to be done and everything else, and what needn't be done. And you know what? He says, Doc, I want to say something to you. I said, what? You're the 6th doctor I have met for this problem. You're the first doctor who has touched me.
Examined.
Can you imagine?
Yeah.
To know where my pain is. I mean, I thought that is a fundamental job of us to be doing. So it is so critical for us to not to forget that the art and science of practice of medicine is not to look at the scan and to give a medication, but to listen to the story. The patient should believe that you are listening to him and then examine him, because sometimes surprising things have come in in examination of these things. And I'll give you one more story here about the pain. One lady has gone to a senior neurologist. This is 15-year-old story with pain in the buttocks going to the back of her thigh. Classical sciatica pain. Okay, so she's gone. Then everybody thought sciatica. He also thought sciatica. He's got MRI. The MRI report from a reputed diagnostic center says D11, D12 slip disc. He refers her to me for surgery. She comes and sits in front of me. I ask her, what is your problem? She said, sir, I have a problem in my back. I have come for surgery. I said, I repeated, what is your problem? She repeated the same thing again. I said, I don't want your scans problem. Tell me your problem. Then she's asking me, when you she's come baggage already. Patient has come ready for surgery. The surgery is simply wasting his time doing all sorts of things. Then she very reluctantly she was upset, but she kept telling me what is this EFO and all of those things. Then I said, please lie down, I have to examine you. Then she says, okay, at the end of examination, she asked me, when will you operate me? I said, get this X-ray and come. X-ray, hip joint, AP lateral. Hip joint X-ray. She was unconvinced, but she said nothing to do. He referred to this doctor. I had to keep the surgeon happy, otherwise he went out to operate me. She goes and comes. Guess what she had? Hip joint tuberculosis. TB of the hip joint. And I told her, you have TB of the hip joint. You don't need surgery. You need this. All this drama was seen by my junior doctor. So after she went out, he asked me, sir, how you knew, sir? You had a very valid point. I said, Papa, she had pain here. This is L5. Where she had the disc, D11, D12. So it's not matching. So what I'm saying is the clinico-radiological correlation, nobody is doing, or very few are doing. People are treating the scan. People are nothing they're connecting. See, 1 + 1 is becoming 22, 44, 88. Something else is being unnecessary surgeries are being done. That's not correct. You have to connect, because any of us, if you do a scan, we'll have some pathology. Yeah?
True.
Correct? No, somebody.
That's what it
And that automatically brings us to the next topic, which is musculoskeletal. The biggest question we're going to talk about is back pain, neck pain. All of us, including you and me, are going to have this at some point of time in our life.
Are going, sir. Also have. The doctor has done a needling to a small muscle here called the rhomboid. The guy's got the needling done, walks out of the clinic, collapsed outside the clinic because the needle went deep, punctured his lung, and he had a pneumothorax.
Really?
Yep. So anything sharp in your body, it can
you have a sense of
wherever.
That means you have to be responsible sense of what's going on. So it's very critical.
So we do it under guidance so that when we know we are putting the needle in the right place, We are not injuring any other structure.
Got it.
And because we are so precise with where we are, the dose required to cause relief can also come down.
It's like a targeted medicine.
Absolutely targets, like finding the center of the dart on a dartboard.
Correct.
Right? So you're very perfect with that.
Perfect. Dialogue I have seen and I use very regularly in my pain presentations, that low back pain is the single biggest cause of loss of man hours in the world today.
Absolutely.
So, that's how it is going. So that is where we are coming to this back pain, neck pain. So what is your take on musculoskeletal pains in general? You can tell our viewers, and then go down to the neck pain, back pain, the spinal pains, and the non-spinal pains. Can you give us?
So musculoskeletal pain, as you rightly said, is probably one of the biggest load which can disrupt a quality of a life of a patient. Right? You could have axial pains, which is pain in your neck, back, or lower back. Or you could have peripheral joint pains. All can come under the broad umbrella of a musculoskeletal pain.
Muscle and bone.
Muscle, bone,
joint.
Yeah. Right? So all of them comes under musculoskeletal pain. Usually, most of them don't need anything except for a little bit of discipline in your life. The treatment is to inculcate a little bit of discipline. Because most musculoskeletal pain comes in from poor posture.
Correct.
Poor habits or bad habits, as I want to call it, and lack of discipline.
Correct. You're holding the phone like this.
Like that.
Simple example as that.
Or sitting in front of the computer as if the computer is going to give you a kiss. Right? So that close to the computer.
Or lying down in a funny posture, looking at the
stupid
phone for hours together, some movie.
Like the fourth monkey in the Gandhi statue is eat, see no one, see no evil, talk no evil, speak no evil. The fourth one, don't speak at all. Don't do anything, just look at the phone. So so this has made a big difference. Although we have progressed technologically, the world has come into our palm, but it's also come at a cost.
Big cost.
Right? So the thing that I always tell my patients coming, they always say, why don't you do an MRI? I said, what will I do doing your MRI?
And they get upset if you say no.
If you say no, they will get very angry.
They think you are some quack or something like this. Something
black magic.
Black magic.
So usually it's the IT sector, because they do spend a lot of hours in, and most of the times the problem is
ergonomics. I think that's a very strong message in ergonomics. We'll talk about it later. Yes, continue.
So, simply when we've examined and ruled out something, so what we call red flags in our practice, and we've ruled out that there's no need to, do anything significant, most of the times, maintaining a good posture, staying hydrated, eating the right food, doing some form of exercise for at least 1 hour a day, and getting 6 to 8 hours of sleep is itself an absolute magic cure for 80% of these problems.
See, I'll tell you what is happening. I spoke to that neurologist on stroke. He is saying the same thing. I am talking to a pain physician. He is saying the same thing.
So it must be true, right?
What's going on? I mean, it's like a vaccination program, no? But yet people don't do it. Maybe even you and me are
possible. I may not practice 100% of what we preach.
Yes, exactly.
Right? We don't.
Because it looks very easy.
Absolutely.
It looks too easy.
But if you have an emergency coming in the middle of the night, you will go and finish your work. And then when you have to go back the next day, where is the 8 hours of sleep?
Exactly.
Not there.
Exactly.
Right? So if you say, no, I want to sleep for 8 hours, the hospital will say, please sleep. Don't come back.
Correct.
Right? So, but to a large extent, people who don't have to run in for emergencies what we do, if they can practice these 5.
Can you repeat those things again?
So, maintain a good posture.
Correct. Ergonomics,
right? Hydrate yourself very well.
Correct.
In India, people want to have all sorts of water except the actual water.
H2O.
Other than that, any form of water will do.
That they're copying the West. In the West, if you go, they only drink beer. And if you have to drink water, they'll say you drink from bathroom.
Exactly. Because the tap water is supposedly very good. Right? So, yes.
Crazy.
So hydrate yourself well.
Either the aerated drinks or beer.
Avoid alcohol, smoking. Big, we all know that smoking is one of the very important causes for spondylolysis.
True.
Right? The abused word, spondylolysis, is because of the abuse that they are doing to them. 8 hours of sleep. This is something that I always stress. Chronic pain, people who develop chronic pain, if you dig into their history, you will inevitably find poor sleeping habits. They will either not sleep or keep playing with their phones, or for some reason, sleep is affected. And when you say sleep, I also mean the quality of sleep.
Correct.
Do you sleep for the heck of it? Do you get up waking fresh?
Correct. That's exactly.
And do
So
you
that's the
feel like
only
you've-
way to know we have got up well, when you wake up fully fresh, ready to conquer the world,
Absolutely.
rather than crawling out of
Crawling and
bed and
getting out of
literally,
the bed.
yeah.
And the last one is I can never stop emphasizing on the importance of exercise in your life.
Agreed.
Right? 30 minutes of, if you cannot do, I'm not saying go to the gym and lift weights, but do 30 minutes of walking, jogging, running in the morning, and do 30 minutes of jogging, walking, running in the evening. That's it. If you can swim, great. Right? But jogging, running, walking, you can do wherever you are under.
Agreed.
From the Arctic pole to the Antarctic pole.
Correct.
Right? You can do it anywhere. So ensuring that these 5 disciplines will make sure that not only those non-communicable disease, diabetes, hypertension, but it will also get rid of the 5th largest problem in the world, which is chronic pain.
So it's like a big bazaar plan. Buy one, take
Buy
3
one,
free.
get 5 free.
Five free. Chalo,
free.
5 free. So posture ergonomics, most of us don't even know what's the right posture, which is where you have to meet a specialist, like a sports physiotherapist or somebody like that who does this assessment. So many times when I send for pain, I specifically write ergonomics.
Absolutely.
Because most of the issues is not only to solve the current problem of pain, to prevent the pain from coming back
also.
And you have to find the cause of this pain, only then you're going to have a more longer term solution.
Absolutely.
And in spite of that, it comes back, I tell my patients, like you service your car every 3 months. You come every 3 months, get this, you're doctor. And they have a wry smile on their face, but that is not a bad idea.
Absolutely.
Because eventually if you can make it remain pain-free for 2-3 days or something, then why not?
Why not do it?
Yes.
Yeah, but simple things like, when you're sitting in your system, in front of your system for long hours, simple things like getting up after every 1 hour, walking around, come back. When you sit, make sure your spine is erect.
Correct.
And then they come up with all sorts of funny gadgets on Amazon. Very expensive. I said, don't do anything. Just take a towel, roll it and keep it on your back.
Correct.
That will keep your spine straight.
Correct.
You do that in Bangalore traffic. I was telling someone today, it's the only city where distance is measured in units of time. Where do you stay? 1 hour away. How far is your house? 2 hours away. Right? Because you're spending that much time in traffic.
Correct.
So when you're doing that, support your neck, support your lower back, and go a long way in, getting rid of these problems.
I agree.
Ergonomy, again with the mobile phone. Most of us, given this is it. So the load that it puts on your head is equivalent to having a 60-pound weight on your head.
And it's not transmitting down.
It's not transmitting down. It is just going from here to here.
Correct. Very true.
Learn to use the mobile phone a little more responsibly.
Got it.
Keep it at eye level. This is the usual conversation in my OPD with a lot of patients. Many of them feel bad that they have to pay to listen to this.
Yes.
But, something very simple.
I agree. In fact, many of them, I'm known as a doctor who doesn't do surgery unnecessarily. So people come to me for second opinion. Do I really need the surgery? And many times the pain generators are somewhere else.
True.
So we come to that topic, so people have a back pain or a neck pain radiating down radiating down the leg. Many times the MRI scan of either the neck or the back does not really show a matching problem.
True.
That is or a disc prolapse is what they say, a small disc bulge, but not explaining this. They're doing all sorts of things. They're not happy. And then they go around shopping and finally they'll end up with somebody like me. And when you actually examine, they have tender points everywhere. Now, those tender points can be either in the muscle or can be in the joints.
Yeah.
So, can you tell our viewers what are these muscle tender points and what are these joint pain that they have? Can you explain what's going on there?
When you say a tender spot, it is a localized. We use the tender spots more with respect to muscle.
Okay.
Muscle. Tender spots used with trigger points.
Correct.
In a reversible manner. So that's a very hypersensitive area in the muscle, which has gone into a spasm. Usually when our body goes, again, like pain, spasm is a protective mechanism.
Correct.
It says don't move.
Correct.
Which is why when we have acute back pain, you realize the patients don't move forward.
You splint the back.
You splint the back. It's like, it's a natural splinting mechanism.
Correct.
But if this spasm over time should get better. If it doesn't get better, so you have a localized area of a spasm in the muscle.
Like a knot in the muscle.
Absolutely. The right word is a knot. I was just trying to think of the right word, right? So it develops a knot. And this is palpable. When you touch it, it feels like a very hard area.
Correct. Oh, and they jump, huh?
And they
If
jump. When you touch it, the moment they jump, because it's very, very
very
painful.
painful. I agree.
Very, very painful. Usually happens because of some muscle damage, which hasn't healed properly.
Correct. Or repetitive.
Or happening on a repetitive basis.
Because of poor ergonomics.
Whatever reason. So this, many a times when we see the scan and we find that what we see on the scan does not match even 5% to what the patient is reporting. Many a times is because they have something called a trigger spot, trigger points there. The treatment for the trigger point is actually very simple, right?
But the pain is dramatic, excruciating.
Absolutely.
Yeah.
But the relief of pain after treatment is also extremely
I
dramatic.
agree.
They feel like, the word they use is, doctor, I feel light after this treatment.
True.
So all that you need to do is have a good physio, have a good team, which does something called manual stretching.
Correct.
Right? And myofascial release. So
correct.
A good myofascial release, a good stretch, and continuing these exercises, stretching programs on a day-to-day basis will make sure that you don't get it back.
Correct. Like brushing teeth. I tell them, like
brushing your teeth.
Do this.
We seem to say a lot of things in common to our patients.
Till you die.
Okay. So that is one. So in spite of that, if things are not improving, then you'll try medications. You try the routine run of painkillers, muscle relaxant. If that doesn't, then we do something called needling.
Correct.
A needling can be dry needling, where you put in a needle into that area and just let the needle be there. So what that does is the needle acts as a irritant. That signal goes to your brain, and the brain then sends a message down to the muscle saying, please relax. So it's a very natural way of breaking the spasm.
Feed-forward feedback mechanism.
Absolutely, feed-forward feedback mechanism. Sometimes we do, when we can't do a dry needling, then we do something called a wet needling. So where we inject something into that knotted area. Usually it's a combination of local anesthetic. Now people are doing everything, including tea, coffee, into that area.
Really?
I was joking.
I have no idea what is going on.
No, but this is something I use very often in my talk. Other than tea, coffee, everything else goes. So yeah, so we use glucose, we use steroids, we use ozone, a lot of chemical stuff that goes in there just to break the spasm, followed by a good exercise and rehab program. Usually will sort the problem.
I agree. So the bottom line you're saying is, whatever we do, the physio is an integral, critical part of it, and they have to complete the course, otherwise it will come back. And based on how severe the pain is, either you try the physio first before they come to you, or you do that. And I think the stretching and then finding the cause and putting a maintenance program in place, all very important to make sure your pain-free periods are longer and the painful periods become lesser, so that your quality of life becomes better. So suppose, So if you give this injection, how do you do it? Because I know that you're one of the few guys who does this, key guys who does this ultrasound. How is the ultrasound that you do different from the ultrasound a radiologist does? Can the radiologist do what you're doing as far as this is concerned?
Yes, but the idea of what to inject, where to inject, is where I think the art is, right? I know of a lot of excellent radiologists who are better interventionalists. But with what happens with an anesthesia training is, it gives you an insight into what to be used and what not to be used. I think that's the slight edge that you can have, right? So we do it under ultrasound guidance so that we know for sure that the needle goes into the right place and it's not going all over the place.
Correct. Because sometimes it can slip when you put that in.
Yeah. It can go into the wrong place.
True.
It can, we've had patients who have done, the doctor has done a needling to a small muscle here called the rhomboid. The guy's got the needling done, walks out of the clinic, collapsed outside the clinic because the needle went deep, punctured his lung, and he had a pneumothorax.
Really?
Yep. So anything sharp in your body, it can
you have a sense of
go wherever.
That means you have to be responsible sense of what's going on. So it's very critical.
So we do it under guidance so that when we know we are putting the needle in the right place, We are not injuring any other structure.
Got it.
And because we are so precise with where we are, the dose required to cause relief can also come down.
It's like a targeted medicine.
Absolutely targets, like finding the center of the dart on a dartboard.
Correct.
Right? So you're very perfect with that.
Perfect. And I've seen patients, which you have done, and Raghavendra or Hira used to do. It was amazing, magical.
You gave me the wonderful example of this. I think she was a stenographer.
Yeah.
Many years ago. You remember?
Yeah, I remember.
And then that lady came to you as the, like you said, exactly the fifth cervical pain, neck pain.
Yeah, neck pain, and she had.
And then all she had was a
trigger
point.
And I had not understood so much of triggers at that time, because in our training we don't see so much of that. And when Raghavendra told me that, I was looking at him like on Halli Gugu and thinking, what is this he's talking about? And then I was studying like this and see what he does, and then it was magical.
Magic.
Which means that what I'm trying to tell you guys is, you must be wondering, we as specialists sitting here, we are talking as if we don't know what is going. That's not true. What I'm trying to make you understand is, as much as we are specialists in our work, there's so much in this world that none of us know. And that's when the mutual partnerships to say that, okay, Dr. Iyer, why don't you look at this? I'm not able to figure out what's going on, because the scan sometimes doesn't give us the 1 + 1 2 information. It's good for one more brain to look at it, one more hand to feel it, to know what is going on, and then we can get the right result at the end of the day. I still remember the same story of my own father. 10 years ago, when Raghavendra treated him. So he had a strange pain, he's now 85. So, he is fit and fine, even now drives his car, plays his golf and all of that. So every time he would look down to eat his food, he would get an excruciating pain starting from the neck coming to his jaw. And only when it bends down to eat, he'd reached a stage where he had to keep the plate here and eat. Otherwise, he's fine. So what do you do? There's no point putting pregabalin for him, because he's only getting it like this. And he would actually have to hold his head like this and lift it up.
Oh my God.
And then I got an X-ray and got a CT scan. And if you see the cervical spine, you'll jump out of your chair. It was so bad.
At that age, you'd expect it.
I looked at it and said, oh my goodness, what am I trying to do? It looked like a C2 neuralgia and things like that. Then I said, by that time I'd already got, introduced to the Raghavendra's, school of medicine, pain medicine. I said, let Raghavendra see. And I got him to see. And he said, sir, there's a trigger points here. And he needled him in the OPD. And it's been 10 years now. Even now, that pain has not come back. And my dad is so happy. Every day morning he says, I'm doing Raghavendra's exercise. He doesn't say I'm cervical spinning. He says Raghavendra's exercise. It is so, how patients are, and he's so happy, so contented, no medicines to eat, no hangover of the medicine. So that's why, guys, I'm telling you, to find which nut to tighten is very, very important to know, to have a good quality of life with minimum side effects, because medicines are not there.
Absolutely.
So now you were talking about ultrasound guided trigger point blocks. You also use ultrasound guidance for the facet pains. I think you should talk a little bit of this facet joint and pains, because I think it's very important for back pain, neck pain people to know that there's something more that causes pain generated.
So facet joints are nothing but joints in your spine. Like we all have joints everywhere else. There are joints in the spine which help in movement of the spine.
And they're on both sides.
Both sides, either side, starting from the base of your skull right down to your bottom bone.
Correct.
These joints, like any other joints, over a period of time can get worn out.
Correct. And especially when they're mobile in the neck and the back.
So
low back.
The cost of mobility is wearing out.
Correct.
Right. So when it gets worn out, it can be a source of pain.
Like the knee joint.
Like the knee joint.
Correct.
Right. So anything in your back will present as back pain. So you could have neck. The differentiating feature from a disc prolapse is that usually the facet joint pains tend to stay in the area of pain.
Correct.
Do not go down to the hands or leg.
Correct.
Gets worse on something we call extension. So when you look up or you're bending your back upwards is where you feel the pain most. And when you're turning from side to side. And that's usually the cause. Facet arthritis or facet related joint pains are a little more commoner in the 50 plus age group.
Correct.
I wouldn't think of facet as a very common problem in a 30-year-old who's coming to me with neck pain. I would think of other causes.
Correct.
Facets are very easy to treat. Many of the times the MRI will miss the diagnosis. So the MRI is very interpreter based.
Correct.
So if I'm seeing the MRI and to me that joint looks normal, he will say the facets are normal. Many times the MRI, they don't comment about.
I was just going to say that.
They don't even comment about it because they don't find a pathology.
Or they don't look for it. I'm not sure how many of them are, let's be honest, how many of them are reading it if I don't write it there. If I'm saying L4, L5 facet, if I specifically, then they will look for it and comment on it.
No, but when I had an MRI, and very recently, about 4 months ago for my neck, And the guy gave me an elaborate report. And it was everything mentioned except the facet. So I called the radiologist and said, are you sure there's no facet? He said, if there's no pathology, we don't mention it. So I think so it's very individually
It's based on training.
Training and interpreted even. Now, just because your scan doesn't report it or a scan says it's normal, need not be that it's not the source of pain. It could very well
because
be
it's like a diffuse axonal injury.
Absolutely.
You can have a deeply unconscious patient with normal looking CT scan.
Absolutely. Normal looking CT brain, right? So we tend to use, so one of the ways that we do is we do a diagnostic block. Now, a diagnostic block is we give a little bit of local anesthetic into that. And if the pain goes away, so you know that's the problem. Traditionally, this is was being done with X-ray guidance. For the cervical spine, we've started, and even the thoracic spine, we've started using ultrasound because we tend to delineate the joint a little better. So a needle placement is now more accurate with the ultrasound, but we also use the X-ray to make sure that the needle is, because the spine is a radio opaque structure. So a hybrid method is always preferred over any one of them. For the lumbar spine, it's challenging to image the lumbar spine with the ultrasound. So we tend to use X-ray guidance to do facet-related procedures or nerve root related procedures for the correct. But the ultrasound is an excellent tool.
I agree.
It localizes, it makes sure that your needle goes directly there.
So I got introduced to ultrasound first time from Hira.
Yes.
So that's when he showed me, and I realized that it needs a different handpiece.
Absolutely.
Which I didn't know about the probe and different probe. And then after that, he showed me when, it's amazing what is possible and how,
True. Ultrasound has definitely revolutionized the field of interventional pain medicine. A lot of problems which needed admission, going to the OT, and, has now just become an outpatient.
And much cheaper because,
much cheaper.
Outpatient
procedure.
Outpatient procedure is much cheaper also.
Absolutely.
So you give the a diagnostic dose as what you said just
diagnostic block first.
Yeah, first block. And if the pain gets better, which is what I tell my patients, then if it comes back, and then obviously physio has to be an integral part. And then you do a permanent, if it comes back, with the radiofrequency.
We do an ablation of the nerves.
So radiofrequency ablation of those joints also is the same thing that they do. So it's amazing what all is possible.
And this can be applied to any joint.
Any joint. What do you mean? Like a knee joint?
Shoulder, knee. Hip, for example.
I see.
So you can
like a frozen shoulder also you can do all this thing. Oh, what
frozen shoulder has easier options.
Okay.
So all
what do you do for a frozen shoulder?
All that it needs is a guided injection into the joint.
Okay.
And so in frozen shoulder, basically the capsule is contracted.
Correct.
You just need to expand it. So you put in some saline, put in a steroid, you break open the adhesions, your frozen shoulder is treated.
So just to tell our viewers, shoulder joint is the most unstable joint. It has the least bone. Okay, because it has to move in the most complex ways, and because there's a lot of ligaments that the small micro injuries happen in movements, and that heals and then tends to tighten a little bit. That's where people like him can help. Very common you see frozen shoulders in diabetics especially. And they come to me. How many
frozen shoulders
come to me with neck pain? And then when I tell them it's the shoulder, they actually look for it doubtful. I said, I'm coming here, he's showing here. Then I have to demonstrate to them. The classical thing I said is, touch your back, and they can't do that. True, and then they say, at least there's isme kuch dum hai. They do that. And then once they go to you and get it fixed, they say, it's like that. So it is so funny, because I can see that on their expression, but they don't want to say anything beyond that. So guys, we are just trying to make you understand that, sometimes, we make statements like this because we understand the science of pain medicine, over time of seeing so many patients. Knee, what do you do for the knee joint? I mean, what all do you rather? Not what do you do, what all?
Knee is an enigma in because it's far more common, right? With life expectancy of patients increasing, we see a lot of knee joint patients.
Correct.
Now, typically knee arthritis, as we all know, has 4 stages depending upon how bad it looks. There are multiple ways to treat a knee joint pain, but typically when you have a grade 4 arthritis, the only realistic cure is a surgery. You need a knee replacement, period. Right?
Correct.
Now, if you have a grade 1 arthritis, you can just get away with physiotherapy, weight loss, right? And go a long way in improving your knee pain. We don't even do anything for them most of the times. Now, if patients who have grade 2, grade 3, then, one of the things that we do is in our body, the cartilage that surrounds the knee joint also secretes a lubricating fluid.
Correct.
to keep the joint open.
Yeah, like
Lubricating, just so that the further damage is
Correct.
not there. So we have a substitute like a gel, which we can inject. Many a times, if we see a lot of inflammation in the joint on the ultrasound, we give a little steroid there so that the inflammation subsides. In patients who are fit and who are not on blood thinners, we do something called PRP therapy, which is platelet-rich plasma, coming under the aegis of regenerative therapy.
Correct.
We do that. And, if with that things don't get better, then like we do for the trigeminal nerve, we burn those sensory nerves, which are pain sensing fibers of the knee joint. So that's again done by radiofrequency procedure. So the spectrum of treatment for knee joint is vast. But what I tell them is, irrespective of what we do, it is ultimately what you do with your knee that matters.
That's what patients need to understand. They want the doctor to do the magic. They don't want to do anything at the end of the day, or continue to do the nonsense that they're doing to get the pain worse.
The patient will do the same amount of physiotherapy post-surgery. But when you give them an interventional option, a less interventional option, they want that to work as the magic and cure them pain off. Right? So I tell them that my job is done. I'm not going to do anything more. It is now you who has to take the extra effort of meeting a physio, working towards strengthening your muscles, losing weight, taking care of your diet. And that a lot of patients have improved that way. I tell them that what we do is not going to reverse the arthritis. It's not going to make your knee joint look 30 years younger. But the pain that is disabling you from doing your day-to-day work will get better. But use that as an incentive to improve the joint health.
Got it.
Over time, the arthritis you are bound to age.
Correct.
There is no magic anti-aging medicine.
Absolutely.
Right? So when it gets bad, then, we'll have to look at a definitive form of treatment. But till then, delay that to as much as possible.
Got it.
Right?
So I think we had a great chat,
Yes,
I think we have covered some very common problems that people face. And we have actually shown people that, I think I'm quite sure I can say confidently we have demystified a lot of these things, the myths. So are there any more myths about pain that you want to tell our global viewers?
Yes.
And also any take-home points, if anything that you have to say, we'll be very happy to hear that from you.
So one of the things that I hear a lot from my patients is when they come back after a variable period of having suffered a problem, is that, so I ask them, why are you coming after 8 months, 9 months? So a lot of them tell me that we were told nothing can be done. So what I tell patients is, don't suffer. Look for options to reduce your suffering.
Correct. Which is reduction of pain.
Reduction of pain. And the other thing that I tell them is, all of them come back, make sure you do something and remove my pain off. So this remove my pain is the biggest myth, because many a times removing pain in entirety is difficult, because you are not reversing the pathology that is causing pain. For example,
it's the wear and tear.
Absolutely. So that's a normal wear and tear. You've seen that patients with back pain.
Correct.
Remove my pain once and for all. One shot.
That only happens in movies.
Even in movies now, people are getting realistic, So, long story short, don't suffer is the biggest motto that I follow.
And probably he is not promising a cure, or not a cure, a relief of everybody. But I recommend that you go visit an intervention pain physician before you make up your mind, this is it, nothing else can be done.
Absolutely.
I think that is the fair way to look at
it, right? And then many a times we look at pain management. That's why we call ourselves pain management specialists.
Correct.
We don't call ourselves painkiller specialists. We are not here to kill anyone's pain. It is not possible. We have to set realistic expectations.
Correct.
Right? So I have 65, 70-year-old patients coming to me and saying, knee is paining, can you do something? I said, yeah. So I asked them one thing, okay, I will do this, but what do you want to do once your pain goes away? So most of them, the common answer is, doc, I just want to do my household work. I just want to walk around the locality, meet my friends. That's all that I have. So fortunately, in a lot of our patients, the expectations are realistic. So it's very important that when you meet patients, you set very realistic expectations.
Fantastic.
If your patient is expecting to run the next half marathon and he wants you to do something to make him do that, and you know it's not going to happen, please refer him to another doctor who is in a position to probably promise or deliver what he's promised. But I am very realistic when it comes to,
Absolutely.
I make my expectations very clear. Yes, there are certain pains and aches where we can offer excellent pain relief. Trigeminal neuralgia is one of them.
Yeah, I agree.
You know,
the microvascular decompression
or even a radiofrequency or a balloon, they get excellent relief of pain, right? And they don't have to do much. They don't have to go and see a physiotherapist.
True.
They just have to come for a follow-up. But musculoskeletal conditions involve you to work with your doctor and a physiotherapist and take care of your health as much as you expect the problem to get solved. And the longer you do it, the more healthier you will live.
Okay, Lisa. So because you said about trigeminal neuralgia, so we missed one part of it, so I want to add it here. Is other craniofacial pains which mimic trigeminal neuralgia. So I want to tell our audience that every pain in the face is not trigeminal neuralgia.
I was to talk about.
Yeah, so I think we just missed that part of it. So can you briefly tell what are the other pain you get in the face that mimics a trigeminal? Why it's most important for us to diagnose that to make sure we're doing the right thing? I think that's an important thing that we have to do.
So like there have been cases where trigeminal neuralgia has been missed for years. There have been patients who have not had trigeminal neuralgia but have had to take carbamazepine for many years. Simplest problem is problems with the temporomandibular TMJ joint.
Correct.
Right? So a pain there can mimic a trigeminal neuralgia because it occurs on your face. But if you tease the history out, you will realize that the problem occurs more during eating, right? During yawning, during opening the mouth only. Otherwise, they're quite pain-free.
True.
If you ask them when you wash your face, do you have pain? They will say no.
True.
When you get exposed to cold wind, do you have pain? They say no. Right? And then when you actually, like you said, touch the patient, they will wince the moment you touch here. So TM joint issues are very, very, very common. Much more commoner than actually having trigeminal neuralgia. Migraines can be a potential differential to trigeminal, especially, if you have a V1 neuralgia. Other than that, it is, these are the two things that
common,
we see, common ones.
And also we see cervicogenic headaches. Many times of these headache guys have been treated as migraine, but actually the pain is coming
having
from
the pain from the spine.
The history and looking at that and stimulating that will give us the answer.
Better answer.
So again, cervicogenic headaches are something very commonly that we see and mismanaged as migraine for many years.
True.
And make that happen. So I think you see now, I still remember one patient specifically who had what looked like B2, not convinced B2. I think I sent him to you and, he's been taking carbon. I was not convinced, but I was not convinced that I was not convinced, So I thought, let me ask one more thing. And when he came to you and you were also convinced it's TMJ and then he was not convinced that, it was not trigeminal. Because
how can it be such a simple problem?
No, and he was sold on trigeminal neuralgia for so many years. And, and then he called me. In fact, you had offered an injection. He called me, sir, injection. I said, get it done. And very reluctantly, I got it done. Then he came to me with a big smile on his face for two reasons. Number one, pain went away. Number two, he didn't have the diagnosis of trigeminal neuralgia. So he had a double, benefit.
Double benefit.
At the end of the day. I think it is so important, guys, to understand that, you'll also have a smile like this on your face when you realize that the pain goes away or a loved one known to you has relief of pain, because nothing is more painful than pain.
Pain itself, true.
And I've also seen, people with triggers on left side coming down the arm, thinking it's MI, heart problem. Sometimes it comes to the
bundle of ECG and echocardiograms.
And they're coming down to the anterior chest wall and they're going, oh, you cannot imagine what all is going on. So it's so critical, guys, to understand that the pain can be everywhere. And there was a Navina doctor. Now again one doctor is there. Now the doctor it's like that. So it's so funny. But I think we had a great chat.
Thank you, sir. I loved it.
Yeah, I think so. And I think we have covered some very good aspects and we have much more to do for sure. But I think we should end here by doing this. So thank you very much for all that you're doing for society, because I think it's a very important, neglected field. And I'm hoping that, chronic pain gets mainstream more and more. And with more people like you so motivated to do what you're doing, please continue the good work. Please continue to train more people. That's very important. We need more and more people. And my promise is you'll have enough people like me who will continue to refer the right kind of patients to you so that, we can do the right treatment for the patient. Thank you very much.
Thank you, sir. It's an absolute pleasure. Thank you for having me. And as always, it has been a pleasure. like I told you, the day one when I met you to now, it has been a wonderful journey, and I really hope and pray it continues to be that way.
Thank you very much.
Thank you, sir.
So, viewers, as you can see, we had a fantastic talk on pain. But as usual, the housekeeping rules is subscribe to our channel, click the like button, share it for sure, because for pain, so everybody has pain. For sure. Today, you mean robo may be having pain. We don't know about that. So eventually we'll do robo pain. And then click the bell icon. And then don't forget to view our Rebooting the Brain documentary. And the book is available both online and offline. Make sure you do that. But more importantly, stay tuned, because we have more such fantastic visitors coming in, giving us different perspectives to life, to medicine, to everything else. And you love what we're doing. Thank you very much. Jai Hind.
Jai.
So we have another customary thing of gifting our book to our guests so that we reboot their brain. So please accept this from our side.
Thank you.
We'd love to hear your feedback on this for sure. So that we can put it somewhere that other people know, oh, Dr. Iyer has also read the book, so there must be something to go on in that. Especially the chapter on pain medicine.
Yes.
So written by a neurosurgeon. So I want to know whether I've crossed the passing line or whatever it is at the end of the day.
Thank you.
That's what it is. Thank you very much. Definitely want you to talk to our global audience about consanguinity.
Yes.
I think that's one of the commonest causes of this, where the recessive gene becomes expressive because of all this marrying within the family or whatever that is called.
Right.
For us, for the asti, or what we call as the inheritance or nonsense that goes on. Even in our country it goes. I think it must be a global problem, in different ways. What do you think? We've gone so many different countries.
So consanguinity is a situation where most often individuals who come together as a couple to produce and choose a reproductive option are related as first degree.
Blood relatives is what you call.
So these first degree relationships.
What do you mean by first degree?
So if they are two branches of the families, let's say two brothers marry two separate individuals, but their children are first cousins. So if these first cousins marry each other, they are inheriting or it may be the other way, two sisters marry, and they have their own children.
In India, I remember the commonest thing that happens is in Kannada we say Sodar Mava, or the mother's brother. That's the commonest thing they said to keep the the inheritance inside the family. But let me ask you a devil's advocate question. So what? Now I've overdiagnosed. It's better safe than sorry. I'll give a medicine. I mean, what are you trying to tell the audience? It's saying why should this misdiagnosis be so critical? In what sense?
Right. So let me make two very important points. One is that you're giving a diagnostic label that will have profound social implications for this child.
The social impact.
It will change.
Psychological, social.
It will have dramatic effect on parents, their relationships, and to give an extreme example, they may choose to re-examine their history, blame themselves, guilt, all of those consequences.
Divorce, pull the child out of school, so many things could
So many things are possible. So
I
negative
I didn't
outcomes.
realize. Correct.
The second is that if you give a medication, are you weighing the effect of the medication on the
side
brain?
effect of the medication, or what is the effect?
See, we do not have, even to this day, we do not have targeted medication that only work on those affected nerve cells or areas of the brain. We do have a new generation of medications which are more or better designed and so on and so forth, but they blanket the whole nervous system.
Like a carpet bombing.
So because they affect the whole nervous system, there are consequences for cognitive functioning, for the child's school, for his attention, learning, all of those things. Plus, you have other somatic side effects For instance, some medications may affect the liver function, some may affect kidney function, some may affect, the heart, and so on and so forth. And so you're exposing the child to the risks of unrecognized risks of using a pharmacological medication. And so the responsibility lies with the physician to make the right diagnosis and only then prescribe treatment. So one of the critical roles of a pediatric neurologist or a trained physician is to really sift through the evidence in making the correct diagnosis.